This afternoon, our first speaker is Professor Ed Gane, Professor of Medicine, Auckland University, Chief Hepatologist at the New Zealand Liver Transport Unit, proud father of 3 teenage children, daughters. And he's been managing patients with familial amyloidosis for some time. And he got some special training for that at King's College in London in the 1990s. When I brought into general practice 33 years ago in Auckland, one of the partners in the practice was Ed's father, Jim Gane. So that's a long connection, isn't it? And thank you.
Thank you. Okay. First of all, I'm delighted to be here, and I'd just like to thank Jamie and Aubrey and the New Zealand Amyloidosis Patients Association for putting this together. I think this is long overdue. As we've heard throughout the meeting, this has been a disease which has been largely ignored, and it's time that we try and get together and have a coordinated effort within this country. And I think follow the lead of what happens in Brisbane, New South Wales, Brisbane, Sydney and Melbourne, and have at least a virtual multidisciplinary team here. Now, why am I involved in amyloidosis? In fact, people with amyloid have a normal liver, and as Lou said, I'm a liver specialist. I became involved in a way where I left, after I'd done my medical training here, I went to London to King's College to learn about liver transplantation, because we wanted to open a program in New Zealand. Up until then, all our patients went to Brisbane or Sydney. And whilst I was in King's for 5 years, and we ran the amyloid transplant program, which meant that people from throughout the UK and much of Europe came to King's College for their liver transplants. Because although the liver is normal for hereditary amyloidosis, the liver was a factory which made the abnormal protein. So I ended up looking after dozens of patients who underwent liver transplantation for this condition. And when I came back and we opened the program here in Auckland, I was asked to see patients. But unfortunately, these were patients who were usually very sick. And I think hopefully my presentation will show you that there are better treatments than liver transplantation, which can work early in the disease. I'll try not to duplicate too much of what has been said, so I may skip over a couple of slides. Oops, sorry, I forgot. Yeah. Okay. Next. Yeah, so that you can skip over this, as I say. I've worked in several of the studies, and if you can carry on. So I'm going to talk largely about hereditary amyloidosis, but some of the treatments will be equally as effective in wild-type transthyretin amyloidosis. And there are a number of forms of hereditary amyloidosis, depending on which is the abnormal protein. We've talked mainly here about transthyretin. You could click next, or shall I try? Yeah, thank you. But fibrinogen alpha chain is also a type of amyloidosis which is hereditary, autosomal dominant, which means that you only have to carry one copy of the gene to get the disease. Autosomal dominant means that only one of your parents needs to have the condition and half the children will have it. And fibrinogen alpha is a different disease from what we've heard about up until today. It affects, but I think it's important to talk about it. I think some people in the room have this type of hereditary amyloidosis. And it's probably more common than the transthyretin amyloidosis here in New Zealand. We have 2 very large families, or what we call kindreds, who suffer from this mutation in the North Island. Unlike transthyretin, there's only really one mutation. There's another rare one, but this is the mutation which almost everybody has, and certainly everyone in this country. There's often not a family history if the onset is late in life. And many people with this mutation don't get the disease, but the disease is quite different. We've heard all today about the neuropathy and the cardiomyopathy. In fact, this hereditary amyloidosis causes kidney disease. Initially, the kidneys get leaky because the amyloid builds up in the kidneys and they lose protein in the kidney. And then once the protein is developed, then that person will develop kidney failure within the next 5 to 10 years. And it runs true in the families. In that family, if somebody develops kidney failure, the other affected brothers and sisters will also develop kidney failure at some stage. It's also associated with premature coronary artery disease. And we haven't heard much about this in Tim's talk, but I think there's if you have any type of amyloidosis, it can be laid down in the coronary arteries. So it is a reason why people can get coronary artery disease or heart attacks earlier in life if they have hereditary amyloidosis. What I'm going to talk about is the newer types of treatment to treat transthyretin amyloidosis. They have not yet been applied to alpha fibrinogen amyloidosis, and I hope that over the next decade we will see the same science, which is fantastic, being applied to this condition as well, because it is important for New Zealand. And the only treatment currently is liver kidney, that's combined transplant. That's the only way to prevent it happening again. But we tend to offer in this country just kidney transplant because of the lack of donors. So we'll turn now to what we've heard a bit about already, and this is hereditary transthyretin amyloidosis. There are many mutations that keep on being discovered. In fact, we had one patient, and I'll just point out, I see these patients purely because I'm a liver transplant physician, and the doctors around the country think this patient would benefit from a liver transplant, but we think that's the tip of the iceberg. I don't think we see many of the patients living in this country with hereditary amyloidosis. And one patient, anecdotally, I bumped into when I was at the Hepatitis Foundation in Whakatane for a day meeting, and this woman walked in and she was talking to me, and she said how she had problems with her breathing and her heart, and it became clear to me that this woman had an infiltrative amyloid. In fact, she turned up having had a new mutation, transthyretin, and she had a combined heart and liver transplant, and has done exceptionally well almost 10 years later. So I think we need to have better referral processes, better pathways for people to get into care, certainly with the new treatments. These are the mutations which we have in this country, so we have quite a lot of different types. Every mutation is a different family, if you think about that. And all autosomal dominant, which means one parent will have it and half the kids will have it, and half of their kids will have it. So that pertains to the next talk on the genetics of this and genetic counselling. So all of these mutations have been reported in New Zealanders, and not all the New Zealanders live in New Zealand. As we know, many of them travel to the lucky country, a few of them come back, but we know that of my patients, many of them have cousins, aunties and uncles who live on the eastern seaboard largely of Australia. Okay, I think you've seen this sort of thing. You know what causes amyloidosis. What I'm going to talk about today, because we've had wonderful presentations over the last day and a bit, and in particular last night from our two Australian speakers, we talked about the different therapies. But today I'm going to talk about how you reduce the abnormal proteins. I'm not going to talk about these neat ways to prevent the abnormal folding of the amyloid. I'm going to talk about how you prevent the building block for the amyloid, that is, you stop the production of the abnormal transthyretin. And here, there are three approaches. They are all genetic, if you say. One is liver transplant. You're taking out the abnormal factory and giving that person a normal factory, which makes normal transthyretin. The other is gene silencing and then gene editing. I'll talk about those in a minute because I think they're going to revolutionise this disease management. Liver transplant is, this is Prometheus. Does anyone know the Greek mythology of Prometheus? Prometheus stole fire from Zeus and gave it to humankind, and as his punishment, the Zeus tied him to a rock and asked the eagle to eat out his liver. And this was the first real recognition that the liver regenerates. And the liver keeps on regenerating. And that's really what has made you. And so the eagle came back every day, and every time it came back, the liver had grown back to its normal shape. And we know that now. We utilise this in liver transplantation, where we can take part of the liver and give of a healthy person, give it to someone else, and both livers grow to the normal size in 4 weeks. So it's a remarkable organ. And that's really facilitated liver transplantation. I'm sorry, this is after lunch, perhaps I should skip over this. But this is a beautiful liver. And so we as I said, I learned about this in King's, and we've managed to apply it here. And as you'll see, we've transplanted a number of Kiwis with this condition. I call it gene therapy for dummies, but we're supposed to call it gene therapy for surgeons, and my surgeons forgive me for saying that. So, as I said, you're taking out the liver, which makes the abnormal protein, and put in a liver which makes normal protein. And you stop immediately the production of the amyloid, the production of the abnormal amyloid. And it stops progression of the neuropathy, which we've heard about from Antonia. This should stop progression of the neuropathy, preventing the laying down of the abnormal amyloid inside the blood supply to the nerves. But it does not always stop the progression of the heart disease, the cardiomyopathy. And that's because if patients from the families where they already have abnormal amyloid in the heart, and not all families get that, that becomes a focus for the normal transthyretin to bind to after the liver transplant. And that is an issue. So if somebody already has cardiomyopathy before the liver transplant, that can progress after the liver transplant, and therefore there may be a need for combined heart-liver transplant, or using treatments after the liver transplant. So far we've transplanted 7 Kiwis, 6 here, one in Sydney. 4 have had isolated liver transplants, and 3 have had combined heart-liver transplants. We initially did these at Green Lane Hospital, and when we got the new hospital, the next 2 were done at Auckland Public. Optimally, you should transplant the liver and heart early before the disease is severe, but waiting for a suitable donor, in particular somebody who's died of the same blood group or a deceased donor, can be very long in this country because we have one of the lowest organ donation rates in the world, unfortunately. So people can wait for years. And therefore, liver transplantation sounds great because it stops the disease, but it is a very limited resource. But the outcomes are good. This is the World Registry from Ericsson in Sweden, because Sweden has most of the keeps the databases for the world for this type of amyloid. And just to say that 10 years you have around 70% survival, and people have retained quality of life. So this is very good compared to other indications for liver transplant. Things have changed. It used to be you had to have a certain type of inherited amyloid to do well after liver transplant. And in fact, most of the patients I looked after in London had what we call the Portuguese variant, Val met 30, and they presented at a much younger age, and they were transplanted usually in their 20s or 30s. And they, as you can see in the blue line, this is survival percentage with years from transplant. They have a much higher survival. And that was when I was involved in the ROC from 90 to 95. But things have changed for liver transplantation across the board. With improvements in operating techniques, our surgeons use very skilled cutting devices. We have expert anaesthetists and intensive care, and much better ways to prevent rejection. The outcomes for both are getting up very well, and in fact, the outcomes for people with the other types of familial amyloid are almost as good as amyloid. We're expecting around 90% 5-year survival. Okay, one way to increase the supply of organs is to do what we call Domino transplants, and we've done one in Auckland, and we did several in the UK. That is where you have one donor, and here it's a deceased donor, somebody who's died and the family's made it a gift of life to donate the liver or heart or kidneys. And that person who was healthy before they die can donate their liver to somebody with amyloid. And that, remember I started off by saying the liver is actually normal. It's a normal liver, except it makes one abnormal protein. And for most people with amyloid, it takes 30, 40 years for that protein to build up enough to cause the disease we know as hereditary amyloidosis. And therefore, it makes sense that person can donate their liver to someone else. So it's called a domino. So the amyloid liver from the person with amyloidosis can go normally into an older recipient, somebody in their 50s or 60s who's waiting for liver transplantation. And they will have a perfectly normal life expectancy before they get old enough to get significant amyloid disease. And this has become common practice around the world now, is that if you have somebody having a liver transplant for hereditary amyloidosis, and they agree, when they receive a liver, they donate their liver to an older person on the waiting list. And this is a great way to double the numbers of organs out there. So this, to me, is a great reason why people with hereditary amyloidosis should get prioritised on the waiting list. Okay, and this just shows that if you have a domino transplant for amyloid, then you've received the amyloid liver, okay, so you're the person without amyloidosis who gets the liver from a person with amyloid, your survival rate is superb, with well over 90%, 5 and 10 years survival. But look at this is also from that database from Sweden, and they collect everyone who has had a liver transplant for amyloidosis in, I think it's the Europe, UK registry, and the US. I'm not sure if Australia or New Zealand contributes to this. But the one thing to note is it's become, obviously there was a time when it went up and up and up and up, and then after 2010 it's really fallen dramatically. And this really coincides into the starting off, and this is what their Ericsson's conclusion was during recent years there's been a decline in reported transplants, and this probably because of the introduction of new medications. And we've heard about the new medications already last night and this morning, how they are changing the lives of people with hereditary amyloidosis as well as other types of amyloidosis, and I think they will remove the need for liver transplantation entirely eventually. So this is what gene silencing is. So gene silencing is, this is your DNA, which has your genes in it. On your chromosome, I think 18, there's a gene which makes abnormal transthyretin. So that the DNA, which is your template, your genome, that codes for something called RNA, and that codes off the DNA. The RNA is made in your nuclei, it goes out into your cells in the liver. This is only in hepatocytes that the RNA is made, and it codes for a protein. So the DNA codes for an RNA. The DNA is the template, that's permanent. The RNA is made each day, it comes out and it makes a protein each day. And that protein, the disease-causing protein, and for amyloidosis, that's transthyretin. So if you're looking at gene silencing, it means you're not getting rid of the gene, that's gene editing, you're getting rid of this messenger. mRNA means the messenger. It's the messenger from the gene which makes the liver cell make the abnormal protein. So gene silencing means you're getting rid of the mRNA, and that's what we're doing. We won't talk about those, we're talking about these things. Translation inhibitors. So they silence the mRNA, and they bind to it and kill it or disrupt it. So gene silencers are these things here. They bind to that and they block the protein. And because you're making this all the time, because that's not affected, you have to give these, we call them translation inhibitors, you give them regularly, lifelong, to knock down the abnormal protein. To knock down the messenger and prevent the protein. So it's very effective, but you have to give it lifelong. And there are two types of gene silencers. I won't go into do data, but called antisense opposite to that, anti or small interfering RNAs. And they've been used not just for amyloid, they've been used for many diseases at the moment, and it's revolutionising medicine. So medicine is undergoing, I think, a huge paradigm shift in the way we treat most inherited diseases. And the first paradigm shift is these gene silencers. And you give them for all types of diseases, inherited or infectious. And all of these trials are underway. You can use it for people with high cholesterol. You can use it for people with cystic fibrosis. You can use it for people with inherited liver diseases which cause cirrhosis. And now they're starting to use it for people with obesity to prevent insulin resistance. The potential of gene silencing is just unlimited. But it's this is a hepatocyte cell. That's nucleus, and the two things work in different ways. The Patisiran, which you've heard about, the RNA chops up the messenger inside the nucleus. The Inotersen, which is an siRNA, the other type, chops up the messenger inside the cytoplasm. So they work in two different ways. The two approved drugs, gene silencers. They work at different. So they're not. They could be complementary, but they work in different ways. I'll skip over that. Just say how they work. So we've heard about Patisiran. I won't go on this because it's not head-to-head studies. But Patisiran is that's the placebo. This is the amount of the abnormal protein in the blood. It's an indirect measure of how it's working in the liver. You can see it knocks it down by about 80%. Very, very effective. Patisiran is and prevents the progression. You've seen the slide so many times, but going down is good. That's progression of neuropathy with time, and people who get the dummy drug, placebo. That's what happens if people get the active drug, Patisiran. It gets better whilst it gets worse in the people who are not on active treatment. Patisiran is great, but it is intravenous. I think it's three weekly intravenous injection. And you can get some reactions to the injection, so you need to have a pre-med, usually. So it's good, but it's not, obviously, I don't think it's the best thing in terms of patient tolerability. But the company who make Patisiran, Alnylam, are making a new form of this, which can be given as an injection under the skin every 3 months. And I think that's really fantastic. You can do it at home. It's like having a little vaccine. You put it under your skin, tiny injection once every 3 months. So that will be, although Patisiran, I guess I'd say this is a proof of concept, that this works really well, but the next drug is going to be, I think, really, really convenient and well tolerated for the patients. So that's Patisiran. The next one I mentioned was, and that's approved by the FDA, it's not yet, I don't think it's on the, approved by MedSafe, and it's not funded in New Zealand. What about the other one, what we call the antisense? These are slightly different graphs, and you've seen this many times. Again, blue is people who got the active drug, black is people who got the dummy drug or placebo, and this is changes in neurology worsening, or you have to say is that if you got Inotersen, you did much, much better than if you got the dummy drug. It's a different molecule, and it has to be given weekly, but it can be given subcutaneously, but it has to be given weekly. And that's not great either, to have to dose yourself every week. So this company also have seen the light, and they've got a second generation drug, which is currently in development. We have one patient on the trial in Auckland, where it's given, again, under the skin, but it lasts much longer. It can be given monthly. So the new drug for Inotersen can be given monthly under the skin. And the advantage of that also is it won't have some of the side effects, low platelet counts, which you have with the previous thing. So I think both companies are making much, much better formulations which will make this far more acceptable and easy to administer. The issue always, though, will be having this funded in New Zealand and Australia, and I think we should talk about that. It's also approved by the FDA. So that's gene silencing, right? I've talked about how gene silencing works. Abnormal gene, making an abnormal messenger, which makes an abnormal protein. So that's a DNA messenger RNA protein. And gene silencing gets rid of the abnormal messenger. Right. Oops. Now, let's have a look now at gene editing. That's gene silencing. Now, how does gene editing work? Gene editing goes beyond getting rid of that, a pair of scissors which cuts out the abnormal gene and lets the DNA form again without the abnormal gene in it. It's a pair of genetic scissors. And there are many types of gene editing under development. Some of them put something else back in its place, some of them just remove the abnormal gene. And the one we're going to talk about for the next few minutes is a thing called CRISPR. So CRISPR cuts out the abnormal gene, therefore you don't make the messenger, you don't make the abnormal protein, and it's permanent. So one shot, permanent treatment for this condition. And this is obviously just entering clinical trials now. And gene editing is changing your DNA. It's changing your DNA forever. It is here. There are two types. I'm going to talk about CRISPR. And it's been used for many different types of diseases. It's already been used in a number of blood disorders and that we call it ex-vivo. By ex-vivo, I mean you take the bone marrow out, you treat it, take out the abnormal gene, which is causing the thalassemia or the sickle cell anemia. These are diseases found in different parts of the world, or is causing the leukemia, and you make them normal, and then you put it back into the person's bone marrow, and they have a normal marrow, they stop having that disease. That's ex vivo, out of the body. In vivo is where you give the treatment to the person, sitting in the bed or lying in the bed. You give them an infusion or an injection, and that gets rid of the abnormal gene. And that is new, and that is what I'm going to talk about. There are a number of trials in development, including a lot of these lethal diseases, and a number of trials for diseases associated not with death but with severe reduction in quality of life. And there are 3 of these trials currently starting or about to start here in Auckland. So the one I'm going to talk to you about, of course, is the one to do with familial amyloid or hereditary amyloid. And we have to thank these 2 women who received the Nobel Prize last year for biochemistry. Emmanuel Carpentier from Paris and Jennifer Doudna from Boston. And they, for the first time, showed that CRISPR, I won't confuse you, but CRISPR is a natural process bacteria have when they get infected by viruses to get rid of the virus. CRISPR is a natural process. They found a way to use CRISPR to do gene editing in people, in humans. Of course, there's a lot of animal trials, so this is something which could be potentially safe and effective in humans. All their trials have been in animals to date. And so they received this for developing CRISPR as the first potential gene editing therapy for humans. And the importance of this photograph is Jennifer Doudna on the right. She's a woman who set up a company called Intellia. And Intellia is a company who is now running the first ever gene editing study in hereditary transthyretin amyloidosis. And it received a lot of press, a lot of it, as you know, controversial press. There have been some things about how can you change someone's DNA? Is that ethical? Is it not? So I've talked about the 2 types. Ex vivo, you take the marrow out, you change it, you put it back. In vivo is you give it to the person. Now there's something you need to know. In vivo, we're not just giving them an infusion of a treatment which will go everywhere. Remember, this is a disease where the problem is in the liver. None of the transthyretin, virtually no transthyretin is made in the eye or outside the liver, small amount, less than 10. So if you can find a way to deliver this pair of scissors just to the liver cells, then you are sparing that person of having any potential changing of their DNA outside the liver. In particular, you're not going to be affecting their reproductive organs. You won't be potentially passing on any mutations to their children if they have childbearing potential. And there are two ways to do that. One is what we call lentiviral delivery, and the other, which has been used by Intellia, is nanoparticle delivery. And nanoparticle, I think we've got on the next slide, is shown here. CRISPR is really neat. This is Cas9, that's a bacterial nuclease, a pair of scissors, and you join it to what we call a guide RNA, which matches the gene for transthyretin. Then you put it in these lipid nanoparticles. And we've used lipid nanoparticles in our research unit to treat hepatitis B with some of the new genetic therapies. These are safe. You need to give patients a pre-med, but they are well safe. And lipid nanoparticles have lipid on them, so they're taken up by the liver cells, which have a receptor on it called the LDL receptor. And that takes up these lipid nanoparticles so they can get inside the liver cells. It is very, very clever. And it goes inside the liver cells and it matches and chops up that abnormal gene and removes it forever. So, does it work? This is the work which won the Nobel Prize, so I'll show it to you because it's important. Here, this is a proportion of cells inside the liver, we're only interested in the liver, doesn't affect other cells, where the abnormal gene is removed from. Of course you want 100%, but you don't need 100%, you need about 80%. And here you can see this is different doses. Low dose in yellow, medium dose in red, high dose in blue. So the higher the dose, the more of the liver cells lose that gene. And you get up to 70%, which is all you need to have a long-term benefit to the mouse or to the human. And over here, so that's the number of the percentage of cells in the liver which are effectively silenced or edited. And this is the effect on what happens in the serum. And you can see that even on the low dose, you're getting a significant reduction in this abnormal protein. But in the high dose, shown in blue, the transthyretin goes down to about 1 to 2% of the pre-dose level and remains there. And it remains there for as long as you follow up that animal in the trial. And they followed up these animals, they weren't killed, they were just followed and had blood tests. And the animals never had a rebound. So it's a single treatment, no rebound. And so 99% reduction in the plasma transthyretin. And the next studies they did were in non-human primates, and they showed the same thing. So they only needed 60% of protein knockdown actually to achieve a benefit with what we think in humans. You can see with a single shot in monkeys, they were getting reduction to just a few percent of protein. And that lasted, again, for as long as you followed up these monkeys. And they're still being followed up, and they remain cured of their amyloidosis. What about in humans? Now this is the first study in the world where gene editing has been done in vivo in patients. So it's a very important study for a number of reasons. And I'll talk about how that could be done anywhere, let alone here in Auckland. It is, the person comes into the ward, and I should just say I've got Shruti in the back. Shruti is our study coordinator who does all the work. She talks to the patients, and she has been approaching patients and arranging for them to come in, and we're keen to have any patients with this condition considered for this. So the patients come into the unit, they have a single injection for about half an hour, and then they stay in the unit for about 3 days, and then they go out, and then we bring them back and see how they are. And it's been, I can't tell you results, but it's, all I can say is it's very well tolerated. It's a phase 1 study, which means it has to be done in a special unit where there's very careful observation during and after the treatment. And it's what we call a dose escalation study. You only ever have a single dose of this treatment. There's only one dose is needed. We start low dose, we go higher doses, and then we choose the dose to go into part 2. Now this study is being run by the National Amyloidosis Centre in London, by Julian Gilmore, who I know many of the doctors in this room work with and collaborate with. And Julian is running this. We were fortunate enough to be asked to participate, largely because I've done a lot of early phase work in my viral hepatitis interest, and we had a ready-to-go centre, and I already had patients I knew who would benefit from this. And so we're involved in this. And currently we're the only 2 sites. The COVID, and I'll talk about this at the end, I think COVID pandemic has actually provided opportunities for both Australia and New Zealand in terms of being able to do really groundbreaking clinical trials. So we're here, okay, we're here, and I can't give you the results in humans, but what I can say is that the results will be released for the first 2 cohorts in about 2 weeks' time. When Julian, as a primary principal investigator, will discuss the results, and these are safety results as well as effectiveness on transthyretin. He will present those to the European Neurology Conference in Europe. I'm not sure if it's virtual, I presume this. And then it will be out there in public for you to see. And then once we've done that, we're going to finish the study, and then we're going to move into an expansion cohort. And we're hoping by that stage, in August, September, the rest of the world will have recovered enough from the incredible restrictions they've had in place in clinical trials because of the COVID pandemic to be able to join the study. And there are a number of sites in Europe and Canada and hopefully Australia. We're hoping that we'll get sites in Australia that will join the study. That is, to be able to do a study like this, you have to obviously go through a number of certain hurdles. You have to show that it's a safe and ethical study to do. And that's been quite a process for us to go through. I'll just say that we have to have a phase 1 unit. We have a new regulatory committee called the GTAC, Gene Therapy Advisory Committee, set up by the Ministry of Health. And we were their first study ever they had to evaluate. We followed on a very thorough evaluation by the United Kingdom. They have their own Gene Therapy Advisory Committee to make sure what we were doing was ethically and morally and justified and carried out in the safest possible manner. And we have to have patience. And we have patience, but we have to have patience. And I think we have to offer this to every patient who would suit the entry. It is currently for hereditary transthyretin amyloidosis. There's a press release overnight, which you can look if you want to by Intelia. This is the company set up by the Nobel Prize winner. And to say that the results are coming out 2 weeks' time and how you can get them. This will change, I think, the way we look at managing not just hereditary transthyretin amyloidosis, but also wild-type transthyretin amyloidosis forever. So I'll just finish. This is a rare condition, hereditary transthyretin amyloidosis, but it is associated, as we know, with significant illness and shortened life expectancy. Different families will have different what we call phenotypes. They will present at different ages, and they may have slightly different diseases. We heard some people get carpal tunnel syndrome, some people get more heart involvement, some people get mainly autonomic neuropathy. But it tends to hold true within that family, within that wider kindred. But the specific mutation determines what sort of treatment we use. As we know, we're a team of 5 million. New Zealand is smaller than Melbourne. We're smaller than Sydney. I guess I'm not sure the size of Queensland, but we should have a multidisciplinary approach to this disease. I think what I see, I'm as a transplant physician, I'm the ambulance at the bottom of the cliff. I see people who have never been seen or been worked up until a late stage. I think we need to use our links to Australia. I mean, personally, Australia has helped with our liver transplant program at the very inception. When we took back the workload they did for us and set up in Auckland, they helped us and really stimulated our growth. And I think we need to collaborate with our Australians. I think we already do. I think we've got strong links to the National Amyloidosis Centre in London. I think Julian Gilmore and Philip Hawkins have been fantastically supportive and have trained many of our experts over there. We're getting better gene silencing therapies. They will improve outcomes. They should remove entirely the need for liver transplantation or heart transplantation. But these are lifelong treatments, and currently they are not really affordable by the patient. And unless PHARMAC change their approach to rare diseases, I think we will be waiting for cheaper versions of the same treatments to come up. But we need to lobby the drug companies and see what sort of cost sharing they will come into. And perhaps we can talk about that at the end. I believe that if this new gene therapy study, that's the name of the drug, is shown to be safe and effective, then that could provide a one-shot cure for patients both with hereditary and wild-type transthyretin amyloidosis. Whoops. And I already mentioned the need for timely diagnosis and treatment. We don't want to see people when at the very advanced stages of their diseases, so that they can have the maximal benefits. And this is just one, really just for thought. I think what we need to understand, I'd like for Peter and Simon if he's on, to comment. I think we have never been, New Zealand is 0.1% of the world's population, so we've never been a popular choice for late phase drug development, because many drug companies don't see us as a source of revenue for marketing expensive drugs. And you know, there are some delayed fundings of high cost treatments for rare diseases by our funding agencies. So that's been a problem for us. I think where we can really make a difference is we are regarded now as a very attractive part of the world in which to do early phase research, including first-in-man studies, such as this gene editing study. I think both Australia and New Zealand have very high quality early phase centres which can work with the clinicians to provide a venue to do this type of research. And I do think that that's thanks to, we have excellent expedited ethics and regulatory pathways in both Australia and New Zealand. So I think that is a way for us to get hold of these new groundbreaking therapies for both Australia and New Zealand. And I think, unfortunately for the rest of the world, but it's true that we have become very much a sought-after place to do research with the terrible effects of the pandemic on clinical research in the rest of the world. And I've already said this, we all need to work together to ensure that we represent a united research group. And that way I think we can bring future trials of novel amyloid therapies. Not just for transthyretin neuropathy, but for transthyretin cardiomyopathy, we need the cardiologists and the neurologists and the hematologists to all get together in this field. So, thank you.